Pure O, OCD, often called obsession only OCD, is something that people consider a little bit of a subtype of OCD. As a licensed therapist, in my own experience, I often find that people rarely are only engaging in obsessing. What oftentimes pure OCD is actually referring to is someone who primarily practices mental compulsions instead of compulsions that are easier to physically observe. These might be actions such as trying to neutralize certain scary thoughts, trying to reassure yourself as to why that thought won't happen or why you'll be okay, trying to internally count or pray or do something to mentally distract or avoid those thoughts, as well as ruminating on them. So oftentimes the most common mental compulsion will be rumination, where you're trying to answer the question and you're trying to be more sure of, will this thought happen or not, or is this possible, or did it occur? So just really any form of trying to escape the uncertainty that intrusive thought brings on. And all of these can happen in our head. Now, they are not necessarily considered any different than physical compulsions. There's no difference in the way it's diagnosed. There's no difference in the way it functions within the OCD cycle. And you can see my other videos on that. So it's really only a difference of kind of description, right? It's a category that maybe will help you connect with other people who struggle similarly with those patterns of OCD, but it's not necessarily different. It's not a different diagnosis. It's not a different subtype. In fact, many people with different OCD themes can experience primarily mental compulsions. Most commonly, POCD, sexual orientation OCD, existential OCD, even harm OCD tend to be themes that you see more frequent mental compulsions than sometimes even physical. But more than likely, what we think is pure mental compulsions only is usually a combination of both mental and some physical compulsions. It's just harder for us to always identify them. For example, many people may Google, right? They're going on Reddit. They're trying to seek reassurance online from their partner, from their friends and family. Maybe they're repeatedly asking or texting their friends. This is a physical compulsion. You have to physically use your hands to go on Google and look that up. But many people don't consider it a physical compulsion the same way they would be able to identify compulsively cleaning your floors 6 times in a row or repeatedly checking the light switch to be a physical compulsion. People will also often avoid going to certain places or entering situations that would trigger these types of obsessive thoughts to occur, which again is both kind of this combination of mental and physical, right? I may physically remove myself from these situations, but at the same time, I don't consider it maybe a physical compulsion the same way I would physically checking and touching something would. But they are treated the exact same. So again, it's more of this just kind of distinction to help you connect. It's not necessarily going to change the treatment, but I will say the typical recommended treatment for OCD, which is exposure response prevention, can just be a little trickier to do on your own if you primarily deal with mental compulsions. This is often just because the compulsions are so fast and so automatic, and often especially if you haven't seen maybe a mental health provider or therapist who's an expert in this, you may have a really tough time differentiating between an obsession and an actual mental compulsion. They're all thoughts after all. So being able to actually distinguish, is this an intrusive thought? This is an uncertainty. This is a doubt that OCD is giving me that brings me distress, is sometimes hard to differentiate from my own thinking, right? Which is my attempts to ruminate or relieve that uncertainty through prayer, reassurance seeking, trying to logic my way or strategize my way out of that intrusive thought occurring. So it can just be hard because it's difficult to differentiate them, as well as sometimes it can be a little more complicated when it comes to coming up with exposures to help you improve. So I did want to offer a few different examples of maybe how you could practice ERP with a case where most of your compulsions are mental. One common example, and usually kind of a lower level So a great exposure to really start out with that I will often recommend for people regardless of subtype for both pure OOCD as well as any other type and variety would be the simple exposure of maybe something like writing down the intrusive thought on paper, physically watching it, and not engaging with the thought beyond that. So for example, if my intrusive thought that I'm dealing with is, what if I'm really a terrible person? Right? And that's my fear. And maybe that comes up when I make small mistakes or when someone's a little upset at me or if I, do something I feel is awkward or wrong, but that's my thought, right? So the exposure I would be doing would be physically writing out maybe something along the lines of, maybe I am a bad person. Once that thought is there, I'm going to practice, and it's very effortful, but I'm really going to attempt to accept that thought, which means I'm not forcing it away. I'm not hiding my eyes from it. I'm not pretending it doesn't exist. At the same time, I'm not really engaging with it. So you'll notice it's kind of a question, right? Like, what if I really am a terrible person? I may be, I may not be. What I'm not going to try to do is ruminate on that by trying to answer it either way. I don't want to replay past events that might convince myself I either am a good person or I am a bad person. I'm going to sit with the uncertainty of, I actually can't be fully sure. I may never know if I'm truly a good person or not, or if I'm truly a bad person. And your brain's going to want to keep whirling. It's going to want to, go through evidence. It's going to want to reassure yourself. It's going to want you to text your friends, and it's going to want you to Google. And what you're going to do is kind of resist that and just continue to observe that thought, right? Which is, maybe I am. I can't know for sure. I'll never be fully certain, right? Continuing to sit with that. And what you will notice is that if you do not engage with the thought, the distress will eventually go down, right? So that's where you're experiencing the typical ERP peak, rise, and then fall of distress, is you're going to desensitize yourself to that thought by simply letting it be there, right? Which is, I don't have to answer this thought. Just because a question is in my head does not mean I need to entertain it, right? It can simply be present and go unanswered. And you will actually notice if you don't answer it, your brain gets bored of it pretty fast, right? It becomes just a question, right? It's just some words on a paper. And that is where your distress will fall. You can also do other exposures, such as writing stories about what your fear might entail. So maybe I'm writing a story, let's do more of a harm thought. So maybe if my obsession is, what if secretly, like, you actually want to harm yourself, right? And you're going to do it at some point. All right, well, maybe I write a story where that actually happens. And maybe because I wasn't praying the right way or reassuring myself the correct way, that I get depressed and I do actually harm myself. And that's my story. And I just read through it. I reread over it. And instead of convincing myself why that won't happen and actually you're going to be okay, the goal would just be to kind of accept that is a possibility. It may not be likely, but that, maybe that happens. But ultimately, this is a story. These are thoughts that I'm able to kind of acknowledge, read, look at, observe. And the less I'm responding to it, the easier the distress will actually be to fade on its own, right? So I'm just kind of sitting there accepting that maybe I could want to harm myself in the future. Maybe this stuff happens. I may not want it to. I'm not planning on it, but it's possible. That's not going to change whether the thought is in my head or not, but I'm not going to avoid the thought being there of that's a possibility. That could happen. These things could occur. Right? It's not about it will. It's not about it won't, right? It's possible, right? So sitting in that uncertainty for extended periods of time is ERP and will work regardless of if the subtype is a little more mental compulsions as opposed to physical. But just to reiterate, again, a compulsion's a compulsion. So either way, it's really treated the exact same. It's more of just a distinction to help you maybe find people who can relate to you. But it is treated similarly. If you need help with this, I highly recommend finding an OCD specialist who practices ERP, which is the recommended therapy for OCD. Traditional talk therapy may actually exacerbate some of the OCD symptoms. So it's very important to find someone who really knows what they're working with. Hope you enjoy and check out some of my other videos if you need more help on the topic.